So thank you everybody for coming or logging in and coming virtually to our, I believe it's our third CDSS Exchange Forum. We are honored to have Fred Wolshin with us. He works, as you can see on the screen, at Chapin Hall in Chicago, and I'm sure he came here to warm up, although the weather must be getting better now, right?
Slowly but reluctantly slow.
He has done really fascinating stuff in the child welfare space. He sacrificed most of an afternoon a couple months ago to walk me through a bunch of work that he's doing and share that stuff. And I thought there are a bunch of people in the department who could potentially be really interested in what he's doing as well. And so without further ado, I'm going to say thank you and welcome to Fred. And I'm also going to publicly apologize because I have to be in the Thomas at 1 o'clock, so I'm not going to be here to wrap it up and say thank you for coming and conclude properly.
Appreciate that. Yeah.
Apologies for that as well.
Yeah.
Greg is here and can handle that responsibility.
Okay, very good.
So thank you very much, and Fred, all yours.
Thank you very much. So if I talk into the microphone, that will broadcast out to the. Oh, that's fine. This has nothing to do with it. That's for in here. All right. Okay. But I have to stay close to this in order to. All right. Let me get my clicker. Yeah. So thanks, Pete and Greg and colleagues and friends here in Sacramento. As some of you may, and some certainly do know, you've been a member of Chapin Hall's Center for State Child Welfare Data, where we gather data from a bunch of different states. And we appreciate the steadfast support that the state has offered us. And this is an opportunity to sort of talk a little bit about some of the work that we've done in the at the State Data Center, not specifically related to California, but as you can see, I've included a reference to CCR and performance-based contracts and the road ahead. I've titled the presentation, So You Want to Change the System. And I think when I talk to groups around the country, I will often ask them, for those of you remote, this will make less sense, but I will ask them, how many people, raise your hand as soon as you have an answer to the next two questions. How many people care about and want to participate in system reform? And how many of you can give me a 3 to 5 sentence definition of what a system is? So lots of enthusiasm for I want to participate in changing one, not so much readiness to claim that there's a definition they have on their mind as to sort of what is a system. And I think therein lies sort of a curious problem. We have something we want to do, but the thing we're concerned with is a little bit mercurial in terms of how we go about defining it. And so one of the things I want to do today is talk a little bit about, well, when we use this term system, what do we mean? Because you want to change it would be a good idea if we knew what that was. And then I want to tie that into performance-based contracts as a system reform, as opposed to a practice reform. And then I think you'll be able to see the connections between all of this and CCR and other things that you might be interested in. So first of all, thank you for inviting me here. It's a pleasure to be here. I'm going to answer the question about what is a system. We're going to talk a little bit about resource constraints. I think everybody understands that we operate a resource-constrained system. But again, it's another one of those terms that maybe lacks as much definition. I think we tend to think about resource constraints, we tend to think about resource constraints as we don't have enough money. But it's actually, all right, very good, yeah, thank you. It's actually a little bit more, it's a more powerful construct than simply we don't have enough of. A resource constraint can limit how far you go in this direction, and it can increase the opportunities that you'll go in this direction. So we want to think about constraints in a more flexible way. We're going to make the case for fiscal reform as part of an overarching strategy designed to move system change forward. And we're going to tie this to variation in provider performance. And one of the things that's unique, I think, to a certain extent about the child welfare system is that we have lots of providers, particularly here in California, individual 501c3 organizations that contract with state or local governments to provide services. And we don't really know much about whether or not it's a public sector versus the private sector, or within the private sector, there's an array of performance. Are they all the same, or are they all different? And in the context of reform, what does that variability in performance mean from a system reform? And then we might not get to this, but I'll meet you at the front door, I'll meet you at the back door. This is a question that really was meant to speak a little bit to the Families First legislation. A lot of emphasis about moving resources to the front door. It sort of assumes that everybody has a front door problem. A lot of states and localities and counties in California will not have a front door problem. They already have very low rates of entry into out-of-home care. It's more of a backdoor problem. They stay a long time. And so differentiating strategies in response to, and how does a systems perspective allow us to see that? And then we'll talk a little bit about a case study. What is a system? So this part is pretty easy. The alignment of structures, process, and capacities towards an end goal. The hard part is the interrelationships that exist between structures and capacities. And these aren't just sort of, you know, the shin bone is connected to the ankle bone. We're talking about interrelationships that are causal in nature. When one part of the system does something, it causes a response in another part of the system. And it's these causal relationships that we want to be mindful of. And the problem, of course, with is that they're hard to observe. Systems are hard to observe directly. And what I want to do is I want to borrow from other disciplines as a way to begin to reveal the structures and capacities that are part of the way we think about systems. And in particular, I'm going to use population biology because population biologists have been concerned with ecological systems for a long time. And because they've been concerned about these things for a long time, there's actually a fairly rigorous science that goes into understanding what it means when we talk about systems. And in particular, we're going to talk about populations, and we're going to talk about the size of the population and the recognition that the size of a population is a function of births and deaths. You can have a growing population in the face of declining births and a rising population in the face of declining deaths. What matters is the relationship between the two, not one direction or the other, but the relationship between the two. We want to see whether or not these kinds of models apply to the child welfare system, and then what insights we might borrow from having taken that particular perspective. In particular, to go back to something I already talked about, with regard to the size of a population, what role do resource constraints play on that problem? So I like to start with the question, why are there so many foster children? When you ask a group of people, they will have a long, detailed explanation: poverty, family structure, mental health, depression. And the reason why there are as many foster children as there are and how it changes over time is because of admission and discharge processes. The admission and discharge processes may be related to things like poverty and associated dynamics, but the reason why the foster care population is as large as it is over time is about the balance between births and between admissions and discharges. And we will analogize in this conversation births and deaths, admissions and discharges. With apologies, I don't mean to trivialize the idea of an admission and a discharge or analogize it strictly speaking to births and deaths, but it's the idea that you arrive and you leave in that context. We're going to deal with this question of resource constraints and ask the question, what sorts of constraints in the foster care system would govern admissions and discharges? So let me throw that question out to the folks here in the room. What sort of resource constraints would control or contribute to admission and discharge processes?
Lack of caregivers, lack of people wanting to be foster parents, or in the case of parents in RSA, the lack of people's ability to get clearance to become foster parents.
Mm-hmm. So think more generally, you're on the right track. So are there foster parents? Mm-hmm. You can't have more foster children than you have beds, strictly speaking. So the thing we're going to be interested in is whether there's a relationship between admissions and discharges in a way that is suggestive of a resource constraint in the form of beds. We just want to ask that question because that's the way they would go about these kinds of questions In the case of population biology, they would say, is the size of the population limited by the availability of food, for example? So we're just going to analogize ourselves into this situation and see where we go. So first thing we want to do is we want to sort of get the idea, because we're not actually going to measure beds. Very hard to do. In the private sector, if you go out and talk to a private sector agency without impugning motives or what have you, and ask them how many beds do you have, they'll be reluctant to tell you. And they're reluctant to tell you because that's a key management thing that they want flexibility to manage around. So we're going to talk about something we can observe as a constraint on people's behavior or on behavior in general. And so how exactly does that work? So let's think about gravity. Gravity is present here right now in our midst. It constrains everything we do, and yet we don't talk about it. We can't observe it, but we know that it's there because of the behavior of the things it affects. So we're going to transfer sort of that idea. We're going to look at the behavior of things to see if in the behavior of what we're looking at, we might reasonably infer the presence of a resource constraint. All right? So to do this, we're going to need some data. And in this particular example, we're going to be looking at 718 weeks of admissions and discharges to foster care. All right? These were aggregated up from 718 times 7 days, over 5,000 individual days of the ins and outs of foster care. Why do we care about weeks instead of the days? It's because you get a little bit of noise around weekends and 3-day holidays, aggregating it up to the week, but we can do it at the daily level or the monthly level or the quarterly level, as the case may be, and we settled on weeks. So we're looking at kids coming and going from foster care for 718 weeks and asking the question, do they move together? Is there a dance that's taking place, a dance suggestive of the possibility that admissions are responsive to discharges and discharges are responsive to admissions? And then we're going to use whatever we find to see if there are policy and practice implications. So these are the observed exits and entries. These are just sort of gives you a general idea of what the trend line is. It would frankly be hard to draw a strong association with because there's not much information in those lines. There was a bump up and then a long decline followed by an uptick, and you can sort of see that they're moving together, but it's not really the kind of detail that we want. These are the actual weekly counts, and this poses the opposite problem. It's very hard to see any real pattern in the data because there would appear to be a lot of noise. In that, the signal to noise, if you will, is a little bit harder to detect, although we'll challenge that assumption in a little bit. And so one of the things we might do is, and some of you have already started to look at the peaks and the valleys and say, well, there might be seasonality in there. And so the next thing we'll do is we'll take out the seasonality and entries. There's an off-cycle peak in admissions relative to discharges, but there are times of the year, and it happens very regularly. Times of the year when admissions tend to be high and they tend to be low, and other times when discharges tend to be high and other times of the year when the discharges tend to be low. And you can see that these are very regular patterns. And one could, from a systems perspective, ask if these times of high discharges are so regular, should we think about deploying more personnel to those times of the years when we know the volume of kids leaving the child welfare system will be much higher than it is at other times of the year? It's sort of like asking the question, should I have more checkout people Saturday at noon at the grocery store or Thursday at midnight? Because I know the volume of people traveling through the system differs. Should I respond to that with an allocation of workforce to manage the increased volume? Or more generally, how am I handling the increased volume? And am I just swapping people from one position to another and then making up for it? And then what does that sort of management of workload do to create other sort of oscillations or changes in what happens to the experience of kids? And so there is some regularity to these ins and outs that we might pay attention to. This is the leftover. So once we take out the stuff that we can see through transformation of the data, this is what's left over. And you might look at that and say, well, you can't make any sense of that. It's as likely to go up one day as it is the number of kids is likely to be high in 1 week and low as the next, or high 2 weeks in a row. There's no apparent order in the data. So we might start from this perspective and simply say, well, at this point, what we're looking at is a random process. And if it's a random process, it means it's going to be very difficult to find the ins and outs. That would be true if there was a resource constraint operating on the ins and outs themselves. So another way is to just change the way we look at the data. We were looking at it as a two-dimensional graph. This is now a true three-dimensional graph. Entries on day 1 is the x-axis, entries on day 2 is the y-axis, and entries on day 3 are the z-axis. And so a random time series fills the space. And what that means is that the number of admissions in 1 week is as likely to occupy somewhere in this three-dimensional space as the next day. It is unbounded in its location other than the bounds of the distribution itself. You follow me? But the next point in a random process will be anywhere in that map. With me? I see some smiles. Okay. So imagine, there were 45 admissions last week. If there's structure, if there's something controlling what will happen, then where the next week's admission will be constrained by that force. If it's random, it can be anywhere. So it could be as likely to be up here in this corner or down here in this corner. These are the admissions, these are the discharges. So one admission could be there, the next one could be there, there. It will occupy anywhere in the map. There's no structure controlling it, all right? If it was a random time series. As it turns out, it's not random. This is a system that operates within the range of that cloud of points.
I know we had a bunch of folks join the room since you started, and on the webinar too. You might tell them where this data comes from so that it's even more relevant. Okay, yeah, this data comes from a state whose data we use in the data archive. And so this is a real state. I can tell you the state, it's the state of Tennessee. We are interested, this happens to be congregate care. And we chose congregate care to start with because we think that that's of the care types, to your point. Congregate care is what we would call fixed cost dominant. Bricks, mortar, if you have a 12-bed facility and you've got 6 people in it, you got to staff it, you got to light it, you got to heat it, it doesn't matter. Kinship care, if you need the home and there's a kin available, you go out and recruit for as long as that home is necessary, but then it goes offline, and the carrying costs of that capacity are very different than the carrying costs of congregate care. So we thought we would find a stronger signal in congregate care. And what you can see is pretty clear, that this system operates within this range. It is unlikely that the next point is going to be in this range here, because over 15 years, it's never been there. This system never visited that number of admissions. Even though the size of the system has changed from 9,000 kids in foster care to 6,500 kids in foster care and then back up again, it never did so in a way that occupies this region of the graph. And likewise with discharges. And both are concentrated around here. Now, if we were further along in our analysis, what we would do is we would color code those points and affiliate them with fiscal years, so that you could see how the map evolves through time in particular regions. And then you would go back to the graph earlier and say which of those points are represented by the highs and the lows. Where in the map were we when we were increasing at the very beginning? Where were we when we had this steep decline over 8 or so years? And where were we when we came back up a little bit? So we could isolate where in the two-dimensional graph the three-dimensional array of points wound up being.
But here you can see that the points are sort of, it's an evenly spaced cloud. In this space, they're more tightly clustered. And so this is the evidence that we have for there being what we would call supply-induced demand. If somebody leaves out-of-home care, someone will come in. If someone is coming in, it creates the possibility of somebody going out. Now, why do they have these constraints, if you will? It's because, as I'll talk about in greater detail, it has a lot to do with the way we have designed the system. All right? This is not by accident. This is responsible, I will say, responsible adaptive behavior to the systems we've created. So practical implication number one. So again, we'll call this constraint bed supply, and we'll recall the dynamics around bed supply. The fact that those clouds of points are more tightly clustered than they might other be if it was a random process, supply-induced demand. And the practical implication, first of all, is that you have to actively manage supply. We did an analysis of state congregate care policy, and there are very few states that have on the statutes explicit policy that says, thou shalt manage the supply of beds. Right? So, and there would be a variety of ways you could do that, but there is no explicit legislation out there except in a very few cases, and then where it is, it's very weak legislation where it says, you don't want to use congregate care, you better manage the supply. And how do we choose to manage congregate care? Well, what we'll do is we'll make sure that only the people who get in are the people who need to get in. So we'll do a clinical assessment. And I want to suggest that in the face of supply-induced demands, there are certain periods of time when the power of an assessment will be relatively weak when compared to the supply-induced component of demand. It's not one or the other. It's the power of one relative to the other in certain historical contexts. Because I think the thing we have to worry about when we do assessments is that the logic of assessment is assess, figure out what they need, as opposed to figure out what they need and then assess. Right? Therein lies the trick with assessments. And there are, I'll say again, situations where the assessment will be a relatively weak counterpoint to the tendency to, I have a bed, it needs to get filled, and we will figure out a way to do that. All a very subtle, nuanced dialogue. I'm not saying that this is an overt conversation that takes place. Oh, we've got a bed, somebody go find me a kid. But the nature of these conversations, and again, I don't mean to impugn the motives of private agency. This is the business they're in, to a large extent because of the way public sector agencies contract with them. And I'll come back to this more to the point. And that goes to practical implication number two. It's the fiscal model that sustains the supply component of demand. And this is why I come back and talk about fiscal reform. If you want this system to behave differently, then we, public, private, inside, outside, have to do something different because of the power of supply. So, making the transition now to fiscal reform. Three phases of fiscal reform. If you think about this as an insurance problem, which of course it basically is, right? You've got three things that you worry about. The Affordable Care Act, all of the conversation was about the first two aspects of fiscal reform. We're going to cover more people with more services. The least talked about aspect of Obamacare or the Affordable Care Act was the changes it would have made to the way services are purchased. If you read closely enough, and you don't have to read that closely, the Affordable Care Act would have done away with fee-for-service health care, by and large. It would have all moved to some sort of prospective, capitated, block grant, whatever the ultimate way of financing, it was going to change that. And we rarely talk about
the third option, we almost always talk about the first two. When we talk about the Families First legislation, what is it? It's expanding coverage and services to kids who are not in foster care. Does very little, does not do much to change the way, for example, states would reimburse private agencies for their part in that. It leaves intact the fee-for-service structure that defines reimbursement for foster care. And I would say that that's the part of this that we want to be very conscious about the decision. I'm not saying you have to get rid of fee-for-service arrangements, that one is better than the other. I think it is a decision about which we need to be very transparent, because both have consequences for the quality of care that kids receive and our ability to manage in the way we would hope to manage. So to make a distinction, we'll talk about, to see what's the difference, what are the opportunities, we'll talk about two different types of reimbursement. One I call retrospective reimbursement, and the other one prospective reimbursement. How are they the same and the different? So in general, all fiscal models are the same. If you want to know how much somebody spends, revenue or expenditure, you need to know how many services they provided and what the unit cost of each service was. So it literally is as simple as that. If you tell me how many days of X you provided and you tell me the average unit cost of those cares, that type of service, I can tell you how much you spent or how much revenue you received. It's a little bit like rate times time is equal to distance. It's exactly that simple. If you know one of those, if you know two of those, you automatically know the other, right? And so what's the difference? So in a fee-for-service system, here, revenue, volume of services, unit cost. At the beginning of the fiscal year, I know the unit cost I'm willing to reimburse an agency for. I'm going to give you $80 a day for that type of bed. I'm going to give you $150 a day for that type of bed. And the provider manipulates volume of services to achieve a revenue goal. What's their revenue goal? Well, they said, I have this many staff, I have this much property, I have this much administrative cost, and I'm going to give everybody a 2% cost of living increase. So next year, I'm going to need $11 million to run my business. And if that's my revenue target and I know my unit cost, I know how much care days I have to provide. If that's the only way I can attract revenue. And I have sat through enough finance meetings of voluntary or not-for-profit organizations of the board where the question that gets asked is, what's our utilization? Why? Because I want to know what the multipliers are. I want to know, are we ahead or are we behind? Because that's going to tell me where we're going to end the fiscal year. Why do I need to know that? Because I have staff to hire or let go, taxes to pay, or property to pay back the loans for. It's the way we've done this, right? And again, I want to be clear, I'm not impugning the motives. If you're a county and you're contracting with a foster care agency, you want them to have quality services. Well, in order to sustain quality services, you have to have regularity of revenue. You can't have an organization that's 50% bigger one year and 75% smaller the next year, and then back up to where it was in the third year. You got to have regularity. Well, these are the mechanisms of regularity. And we've already seen, to tie things together, we've already seen how admissions and discharges dance together, right? So we know that this force is present in the way gravity is present in our day-to-day experience. It exerts an influence on us, and we're better to understand what that influence is and see if we can engineer an alternative way of dealing with the world around us. In a prospective payment system, what we know ahead of time is revenue. So at the beginning of the fiscal year, I'm going to tell you how much revenue you're going to get, and you are free to manage volume and unit cost. So automatically, it's more flexible, right? Because up here, the only thing you can manage is the volume. Down here, you can manage volume and unit cost. So what does that look like? Well, I want to get kids out faster. I want them to use lower levels of care. start sounding a little bit like CCR. I want to reshuffle the mix of kids from one type of care to another. I want to remove the incentives of keeping kids at one level of care because they get a unit cost that's higher than if they were at a lower level of care. Starting to see the way some of this stuff comes together. But the prospective payment system says this is how much money you're going to get regardless of what you do with these two. Not strictly regardless, but these are the variables you can now manage more directly. And let's see where we get to this. So the revenues, as you see here, sort of like how do we come full circle? Revenue is a function of bed days and unit costs, right? Bed days are a function of admissions and discharges. So if you start the year with 100 beds and they're each occupied every day of the year, 365 times 100 is 36,500 bed days. Whether they are occupied each and every day is a function of admissions and discharges. So now we've tied the macro dynamics of ins and outs to the fiscal model. Whether the bed days are used as a function of are kids getting in and how long are you holding them as it relates. And we want to manage those ins and outs through our fiscal models. The two important problems here are the problem of projecting bed demand. We can oversupply, which will strengthen the impulse to place, or we can undersupply, which will create shortages, and therefore we don't get kids in at the right time. And if we don't have a good way of projecting demand for beds, we're likely to put too many out, and then we'll realize we got too many out there, and we'll take too many away, and then we'll realize we have too many away, and you sort of set off this repeated cycle of up and down and up and down, and it tends to destabilize rather than stabilize what the providers are thinking about in terms of their own viability as organizations in a market that cannot, in a sense, declare the demand for the service they provide. Essentially what we're talking about here is the more that you can say about the number of beds we will need going forward, the better off everybody will be. And we don't do what they do in healthcare. Healthcare, they have very sophisticated models that says this is how many beds we are going to need for this many of this, that, or the other thing. And what I'm suggesting is that we don't do enough of that. But let's come back to this issue of private agency variation, because each agency has a different admission-discharge equilibrium, right? What does that look like? So how many people here agree with the possibility that private agencies differ in their performance? It's kind of like schools. Schools are different. We might look at permanency rates, reentries, transfers, placement moves. You might want to add some things to that. I'm not suggesting that this is the complete list, but this is a decent list. Why might? Because if this was a room full of providers, they would raise their hands quickly with a retort to the comment that performance varies. They would say, well, that's because our children are different from a clinical perspective. We occupy a different niche in the marketplace. I'm a shelter. I'm not supposed to have big permanency rates because my job is to move kids from one part of the system to another. So don't hold me to a permanency standard. They work in a different part of the state. Everybody knows that the agencies that serve that part of the state, the regional director there or the county director there, everybody knows. And so you're basically you want to hold us liable for the transgressions of people whose work we don't control. That's the other issue. We don't control that. We don't control the permanency decision. So how can you hold us accountable? Our size, we're a small agency. You can't expect us to have as much success as larger agencies. So these are all legitimate reasons why you might get a pushback. And in the course of things, the public sector has to deal with these concerns. the good news is that they are readily addressable in the sense of once we take this stuff off the table, what's left is variation that is most likely the result of differences in the way the providers do the work. So we look at different populations, we look at their niche, we look at their size, we look at this part of the state they're dealing with, and when it's all laid out, you get differential provider performance. So what these are is, think about this line through the middle here as the state average, and these are the departures from the state average. So that little point is the departure from the state average. The line through the point says, how confident should we be that that point estimate is a significant deviation from the average? So if the line crosses 0, we're not too sure that it's different. It might be below the line, but because the confidence interval crosses 0, we might conclude that, well, the precision of our models, there's too much uncertainty, and so we're not going to claim that that's a different result. The length of the line differs because some providers are bigger than others. So part of the uncertainty is how many cases are you contributing to the overall model? The smaller number of cases that you provide, you give information to the model, the smaller that number, the larger the confidence interval because it reflects size. But as you can see, lots of agencies are significantly below the average. That means their time to permanency is slower when compared to others, and lots of agencies that are doing better. And then lots of agencies in the middle where their performance is, it's tough to see the difference between them and the statewide average. And so putting these facts together, anybody have questions about that? And just to be clear, all of the things I talked to is sort of counterpoint, size, complexity, clinical acuity, niche on the all of that stuff has been taken care of in this model. And so this is as close to an apples to apples comparison as we can get.
Question, are you basing any of your observations on the Dartmouth research from, like, I want to say 10, 12 years ago, there was geographical variation, also supply-driven demand, or,
Yeah, so we're very familiar with John Wenger's work, and we do copy it a lot.
Okay, that was my question.
We're keenly, and that's really where it's in that tradition of supply-driven demand as a contributor to the variability in.
And do you think that that's a factor? Because basically the way I understood it was, look, if I'm a doctor and I have this many patients, and I get all these patients coming in, if they're really, really sick, I'm going to see the really, really sick people. But if the really, really sick people are all getting better, and then now I see someone who's a little bit less sick, well, I'm going to treat them too. And then I'm just going to keep treating until my practice is full, but the acuity sort of.
Yeah, exactly.
As there's less really sick.
That's right. Yeah, no, that's all. These are the subtle dynamics that when we think about sort of population level health, and for the folks on the webinar, the question really is about how do we think about supply effects and the examples that we see in healthcare and the work that's being done in Dartmouth and other places on what's called small area analysis and related topics. My answer to that question is yes. And so we don't think enough about this. I think we have these ideas. If you sat long enough in a conversation, you would hear the ideas. But what we don't do in child welfare is we don't follow through on the idea and ask ourselves the question, well, if that's possible, what are we doing about detecting that behavior in the system we have and then addressing that system behavior? So one of the best examples of that is they did a study of the density of physicians, doctors per population. And what they wanted to know was, how did the density of the physicians affect treatment for certain types of disease categories? I no longer remember what the disease category was, but basically in areas where there are lots of physicians, the way you practice is you have more visits per patient because you don't get a steady flow in, because the steady flow in is being shared among lots of doctors. So the way you make up for that is you have more visits per doctor per illness. Follow me? And so sure enough, that's what they found. And that would be what you would expect in a fee-for-service climate. That if I need 100 office visits for anything in a year, and I can get that from one visit for 100 people, so be it. But if I don't have 100 people, I've only got 50, then my goal is to get 2 visits out of every person through the front door. It sounds draconian and dark and cynical, but again, this is our creation. It was not the 11th thing written down on the tablet that Moses brought down from the mountaintop, right? It's an iron law of our own creation. We shouldn't be surprised that it exists. Recognizing it gives us the opportunity to manage it. We can't pretend that it's not there because it sounds untoward. Yes?
Does that show different health outcomes?
Same outcome. No difference in outcomes. Yeah, great. I meant to mention that, but yeah, no difference in outcomes. Yeah. So the question about the follow-up was about whether or not there was a difference in the outcomes in the examples that I gave. So these are the agencies. This is how they profile. There are legitimate differences between the agencies that states need to be aware of. So implication number 3, providers differ in their length of stay. Inducing more efficient care leads to fiscal strain by putting strain on service volume and unit cost, lower length of stay and lower levels of care, or both. So now think about what CCR is doing. It's asking for less utilization and lower unit costs. And to put it in another way, getting better costs money in 2 ways. It's the investments you have to make to get better, and there's the money you'll lose because you did get better. So it's a losing proposition from a general system macro force structural perspective. This is the way systems behave. Independent of the micro level, because I'm not suggesting that people are out there. This is the context that's created, and people respond rationally to the context they're making, right? The decisions they're making. So it will be easier to adapt to these market conditions if you fix revenue and let providers manage inside that fixed pot. And what you say when you're going to fix revenue is to say, if you don't use as much of the foster care as I have projected you will use in the prospective payment system, you get to keep the difference. And you get to keep the difference to diversify the things you do so that your fit with the market as it's evolving is closer to what the market is demanding of you as a service provider, as opposed to being locked into a reimbursement system where the state and county governments are less and less willing to pay for the thing you provide, and they don't give you a way out of that trap. Okay? So you could take those unit costs and convert them into in-home community-based services. Now, the rub is that if you decide, let's say I have a prospective payment of $15 million, and I'm going to take $3 million of those dollars and invest it in bundles of services that will ultimately be the alternative to foster care that I want to create. The $3 million investment in these alternative services had better work. Because if you don't lower the demand for foster care, you still have $15 million worth of foster care expenditures and a $3 million bill for the stuff you thought would lower foster care. And therein lies a new tension. This is not a tension-free alternative. This is a more transparent set of tensions, responsibilities, risks, if you will. So all of this takes us to performance-based contracts. In the child welfare system, the past is prologue. The one thing the child welfare system is particularly good at is recreating itself year in and year out. We all appreciate what would appear to be a very stubborn thing. I would contend that the reason why it's so stubborn is because of the financial mechanisms, these macro forces, that unless you're aligned with these macro forces, with your policy and practice, it's very hard to dislodge. It would be a lot easier for me to jump and touch the ceiling in a weightless environment than now. I can train, I can strengthen my legs, and I might be able to jump higher. But at the end of the day, my ability to reach that particular goal is constrained by this macro force called gravity. And I want to suggest that the ability of these systems to adapt and change to the social policy goals that we have that says provide only as much foster care as you absolutely need to. Our ability to adapt to that means that we have to get inside the fiscal mechanisms and change them so that they are more aligned with the kind of flexibility that providers will need. This is the idea of reinvestment. I've already mentioned that. You get to keep what you don't use. Subject to federal and state reimbursement regulations. You don't get to keep the federal money until the after the waiver runs out. But this is the theory of the waiver. You're going to share risk. They're already sharing risk. This will feel very harsh to providers, but I'll point out that it's actually not that harsh. You need baselines, you need targets, and you need actuals. You need to be able to say in a prospective payment system, this is how much money I'm willing to give you for what I think is a reasonable estimate of how much work you're going to be asked to do in the foster care space. We think you can bring that number down. If you do, you get to keep the difference as part of reinvestment. The baseline is what established that going forward. The target is, I think you can improve by 10%, and the actual is how close did you come to the baseline or the target, and what do you do about performance relative to those three things. It's easy to integrate with CQI because you're essentially asking people to better manage process, quality, and capacity. I'm going to ask people to do something different. It might be in alignment with an evidence-based intervention. I'm going to ask them to do things better than they used to. We're not going to have as many court delays, what have you, and capacity. We need enough of what we need to make things work better, and price, quality, and capacity are the unit cost drivers. That's what costs money.
And for those of us that don't know what the CQI stands for?
Continuous quality improvement. And so risk sharing does deserve some special attention. It's nothing new. People say, "Oh, well, I'm not taking on those risks. You're telling me that I'm going to live in a risky world." And what I want to suggest is you're already living in a risky world. You're just comfortable with the risks you face because you've been living with them for so long. What are the risks? Well, if the public sector decides to shut down referrals, they don't have any control over that, and that will hurt immediately, right? So that's a risk. Public sector insists on lower levels of care. We're not going to do as much RTF anymore. We're going to go to therapeutic foster care. And as soon as you do that, you hit them in their unit cost. If you're an RTF provider and everybody's going to TFC, you're SOL. And that hits right away, and they have no control over that. That's the state's policy direction, which I believe is consistent with the direction you're going in CCR. Have the providers been trying to push back on that in any way, shape, or form? It's because of the risks they face in a fee-for-service system. Public sector insists on increased time to permanency. We want kids through the system faster. They have no control over those policy directions. Those are their risks, things that hurt them financially over which they have no control. It doesn't get any worse than this. All we're going to say is that we want to make these risks explicit and create a risk-sharing agreement that is completely transparent so that we will have an agreed-upon risk-sharing perspective. In the prospective payment system, what am I projecting? A number of admissions. Well, if I'm a provider, I want to know, what are you going to do if admissions are up 20% because of an opioid crisis? Well, here's our risk-sharing plan. We'll keep you whole on the number of kids coming in. We won't keep you whole on how long they stay because we think that just because you're letting more in doesn't mean you get to keep them longer. We need you to, continue to move things. So on the admission risk, we'll keep you whole, but we are not going to keep you whole on the discharge risk. Got to keep them moving. right? You got to allocate your resources. So it creates a much more balanced, transparent mechanism for identifying and sharing risks with the public sector partners. And so PBC is a way to structure that. A couple minutes, I'll go through this quickly, and then we can go through some questions. We've been doing this in Tennessee for 14 years. We reimburse. Thank you. My pleasure, Pete. Thank you for the invitation. As I said earlier, it's integrated. The state recently got out of its federal settlement agreement. This PBC is an important element of their success in that. One of the things they did was when they went into this, they had a hold harmless so that the agencies could gain, but they could not lose. So you have some flexibility. Again, that's the idea of diversified risk sharing. How does it work? Agencies are compared to themselves. So we're not saying you have to beat the statewide average. You just have to do better than you did last year or the average of the last 3 years. Now, whether or not over a period of 5 or 6 or 7 years, just getting better than yourself is good enough, that's a separate decision. It's a transparent a set of expectations. Do better than you've been doing. For some of you, that's going to be hard because you're already doing well above the average. For some of you, that theoretically should be easier. And so we'll watch what's going on and make judgments about your continued place in the service continuum. Agencies get baselines for outcomes in each area. They know what the state is asking them to do. It's not simply, we need you to reduce time to permanency. This is how much we need you to reduce time to permanency. And this is what it translates into a fiscal impact. If you succeed in that, we're going to monetize the increased rate of permanency to the tune of, and then there's a formula that says, if you do better, this will be your financial reward. If you don't do better, this will be your financial penalty. Yeah.
How do you guard against cherry picking then?
We don't have anything on the front end, and we risk adjust. So you get a rate that's stratified by the difficulties of the kids.
Based on the CAMs or something, or?
Based on objective measures. How long have you been in? How old were you when you were admitted? Are you part of the legacy caseload? Are you a new admission? So there's about 8 or 9, I forget exactly the number, of different strata for each agency. And so kids come in at a strata and they get assigned that. So if, let's divide the world into 2 strata, hard and easy, or long and short. And let's say 1 year they're 50-50, and each strata has a particular projection associated with them. And next year it's 75-25. Well, the 75 kids that are difficult, they'll automatically get the projection for the difficult kids. So the revenue adjusts automatically. So there, each year, the care days are compared with expected use, and the differences are resolved. The surplus is kept. The penalties are assessed, both as contractually required. So agencies know what they're getting themselves into. So in conclusion, macro forces are at play here. I think if we have a conversation amongst ourselves, we will recognize, and you'll hear people talk in those terms. It's time that we recognize them, measure them, and take them into account. It would be hard to figure out how to fly an airplane if you didn't first recognize the problem of gravity. And so that's essentially what we're talking about. If these things exist, there's good reason to believe they do. We should take them into account. These macro forces stand between policymakers and practitioners and the goals they seek for the system as a whole. These fiscal structures induce adaptive behavior. And adaptive behavior does not necessarily need to be aligned with the social policy goals. In fact, I would argue that given the fiscal arrangements and the competing versions of reality that you see when you hear about social policy, and then you look at how the system is financed, you realize that these are tensions, and this is our system. We can change it, but it requires rejiggering the financial system that we've created. So with that, questions, you know where to reach me. But that's it. Thank you very much. And questions? Time for a few questions.
Well, can I ask one question? I mean,
Sure.
A while ago, because we've been really intrigued with performance-based contracting for a long time, we decided not to include that in this initiative, largely because we have a strange situation in the state where we have, we set the rates and license, the counties do the individual kind of contracting, and people often use providers outside of their geographic boundaries, et cetera. Thoughts about, given the complexities of our system, how potentially phase 2 of our work could involve performance-based contracting?
Well, I think they're the normal. Every state wants to believe they're special. California is no different, and I think you would agree we have some subdivisions in the state of California that are even more special. But we encounter that everywhere. These are just problems to solve. They're not barriers. They create unique configuration. But the issue of this county contracts with these agencies contract with these counties. I think the first thing we do whenever we have these conversations is we go back to this chart. If that's true, then what it's saying is that your outcomes are a function of where you live, not who you are, right? And if these providers here are serving the same kids as these providers here, there's a certain level of inequity simply by who happened to have a bed open the day you came into out-of-home care. That's sort of intolerable, right? We wouldn't accept that if we were, our kids were being hospitalized and being served, or we try to avoid that in the case of schools. In fact, the issue around schools is so important that people move to be where the schools are, but families can't move to be where the good providers are. So I think that as long as this is a reality, and this is the reality in California, this isn't California, but some of the work that we've done in our prelude to San Francisco has demonstrated that there's significant variability in the performance of the providers that serve the state of California. Then I think we have to demonstrate the will to sort of remove these kinds of inequities in the service delivery system. So might it cause the providers to reshuffle the catchment areas that they relate to? Conceivable. I think the public sector's obligation here is to create a framework that allows that to happen. That's because the providers know the demand for services in this area and that area, they can make rational business choices, but it's their choices. They're making choices right now that are not working out for kids.
Wouldn't all 58 counties need the same contract, the same performance basis for their contract?
Sure, and that's not a problem. In terms of,
Clearly you don't live here.
well, I've been part of those conversations, and I think it's a fairly typical child welfare conversation where people bring up lots of good points. A fairly sizable majority of them are off point for the immediate conversation. They're not wrong to bring them up if they belong in a different part of the conversation. And sometimes the order in which things are introduced is not a substantive, it's a political gesture, right? It's meant to, move things along, not move things along. It's part of the dance. And again, it's perfectly logical, but if we want there to be a different outcome. So is there a county in California that doesn't care about permanency rates? Yeah. Is there a county in California that doesn't care about reentry rates or placement stability? Now, around that, we may pack different kinds of things, but I can't, if those are the core outcomes, then there's a contract for every county in the state.
So I don't want to dominate,
Yeah.
let some others, and then,
So when we're talking discharge from foster care, are we looking at people who were reunified with the family or adopted out, or are we looking at the whole thing with people that age out? And
All of the above.
what is there any studies going on right now about aging out of the system, prepared or does not prepare people who are aging out?
Lots of studies going on about that. So we keep track of what we call permanent exits and non-permanent exits. And so non-permanent exits are running away, aging out. And so we do keep track of how much of that is happening. And if you want to add in outcomes as it relates to life course outside the system, those are areas where you can expand on the listed outcomes for a particular, segment of the population.
I
Yeah.
think that's people that I know that have aged out of.
Sure.
foster
No, it's a
care.
big issue.
So,
Let me go to the back of the room and then back to you. Yep.
Did maybe these changes have any downward pressure on the number of providers that are available?
Yes. Substantially so. When we started, there were over 80, and now there are roughly 30. Yeah, and there are a variety of reasons for that. But with a graph like this, you can, and the goal here is not to put providers out of business. The goal here is to make provider performance transparent, which is what it should be. You can't justify, it's no longer good enough to justify your place in the market based on your annual report. The public sector has a responsibility to see whether or not providers are fulfilling their responsibility as agents of the state as it relates to permanency and safety. And so you do get to see, and based on this, you might say, and I alluded to it earlier, you might say, well, I'm interested in what the agencies down at the end of the continuum, and this is another part of the tension. I could say to these agencies, you know what? I'd like to give you a chance to get better. I'd like you to, be an agency that has permanency rates that are at least in the middle. But now think about the fee-for-service conundrum. That means they are going to have fewer care days. If they succeed, they have fewer care days. It's what success means. So it makes them vulnerable. Success makes agencies vulnerable. And you don't want that to be the deciding factor. You want to be able to say, we'll give you as much money as we would have given you if we weren't trying to get you better. We'll commit to that. And within that money, which should be enough to do what you're doing, because it's been enough for the last 5 years, we're going to give you the opportunity to use that money differently in an effort to get better at what you do. And then if you do or you don't, and it could be 2 years, you got 1 year, you got 2 years, you got 5 years, but at the end of that cycle, we're going to come back and ask the question, how well did you do with what we wanted you to invest, and tell us what you did. And it maintains the state's responsibility for oversight, but places responsibility for change in the hands of the agency without the harsh fiscal consequences.
I'm going to suggest we have one more question,
Yep.
and then I'll thank people, and then if you have
Sure,
time.
I have time, yep.
Cover around for other questions.
I do, yep. Mm-hmm. There was,
How does it work? Did you find a decrease in variation? Did you find an increase in overall performance? Is there not enough time to go?
we've been doing this for 14 years. Yeah, it's all of the above. So we continue to monitor how well the agencies are doing. Some agencies in the early and middle years, I should say, inside the weeds, we've been through 4 different contractual iterations where the nature of the contract has changed because of provider preferences. So the state said, okay, we get that, and we'll make a change. And then some of those changes didn't work out the way the providers wanted. So in some years, providers, I think in the second year, one of the providers that responded very well at the end of the fiscal year got a check for $3 million unencumbered, because the foster care that money would have purchased wasn't used. There was no claim for a day of care that sat behind that $3 million, so they could turn around and say, okay, what do we do? Do we now, the state is moving in the direction of home and prevention service, in-home preventive services. We have $3 million. Do we want to take that and diversify the array of services that we provide so that we have a better fit with the marketplace as it's going?
Not
Or-
federal and taxable, right?
No, just GR, just general revenue. And then, or they could have said, you know, the population of kids that we're dealing with now is more difficult, so we need to invest in hiring staff with a different skill set. But it's $3 million that they have some, and otherwise they're making, you know, they have marginal amounts of money for what they don't need for each care day to try and figure out, because they're going to lose some, and that profit has to be built into what they think they are going to use and the per diems that they are going to get, and it's just a much more difficult management position to be in. Now, some agencies lost $500,000. They had to, the state recouped $500,000 from those agencies, but it was because they didn't meet their permanency objectives. I mean, and again, under the current situation, people are making mistakes that are costing the taxpayer money. If they decide to do something and it doesn't work out in a fee-for-service system, unless there's a penalty associated with that, the counties of California are gonna pay that money out, right? And now we at least have a context in which to say, if we're smart, this is the way things will turn out. If we're right. If we're not right, then it'll look a little different, and we have to look at the pieces as they appear in the light of a goal we set but didn't reach, which is how improvement happens. So thanks, everybody, for your time and attention.
So before we leave, I just wanted to say a couple of things. We should, in addition to thanking Fred, we should thank Andrew and Karina for helping us out
Yes.
today. And if you guys, if you like this, you should let Pete know, because he's arranging more of these kinds of conversations. So let him know that too. And then Fred, I don't know what your time availability is, but should there be a few extra stragglers, I hope you can.
I certainly can. And thanks to the folks online for your attention, and we'll see you down the road.
Next time we'll maybe figure out a way to get their questions answered.
Yeah.
Thanks, Andrew.